Welcome to the deep dive. Today we're looking at something that could fundamentally change how we assess and treat non-small cell lung cancer, or NSCLC.
We really are.
We're talking about moving beyond, the traditional anatomical staging into this new world of high-resolution molecular prediction using liquid biopsies.
And our source for this is a truly groundbreaking study from 2025 by Black and colleagues. They leveraged the massive TRACERx cohort.
Right, that's a huge patient group.
The huge group. We're talking 431 patients, almost 3,000 plasma samples. And they use this to test what they're calling ultrasensitive monitoring of circulating tumor DNA.
So let's define that core tool for everyone. Circulating tumor DNA, or ctDNA. What are we actually talking about here?
Well, think of it this way. Tumors are constantly shedding tiny fragments of their DNA into the bloodstream. ctDNA is that DNA. So it's essentially a blood test that can tell us if active cancer cells are still lurking somewhere in the body.
Even if they're completely invisible on a CT scan or an MRI?
Exactly. That's the whole point. We call this molecular residual disease, or MRD. And finding MRD after a curative treatment like surgery is probably the single best predictor we have for cancer coming back.
And the big innovation here, as I understand it, isn't just that they're looking, but how they're looking. The sensitivity it's off the charts.
It is. The limit of detection here is down to 1 to 3 parts per million.
1 to 3 parts per million, that just sounds incredibly small.
It is. To put it in perspective, older liquid biopsy tests might have had a limit around, say, 80 parts per million. So we're seeing things that were completely undetectable before.
Okay, so how do they achieve that? The study mentions a tumor-informed methodology. Can you walk us through what that actually means?
Absolutely, and this is crucial to the whole thing. It's not a generic off-the-shelf test.
Okay.
First, they take the patient's actual tumor that was removed during surgery, and they perform whole genome sequencing on it.
So they're mapping out its unique genetic fingerprint.
Precisely. They create a personalized map for that patient's specific cancer. Then, they design a custom blood test, an assay, that looks for up to 1,800 of those specific genetic variants from the original tumor.
I see. So instead of looking for one needle in a haystack,
You're looking for 1,800 specific known needles. It dramatically boosts the signal and allows for that ultrasensitive detection.
Okay, let's unpack this. So we have this highly sensitive, personalized molecular map. How does this really improve on something like traditional PTNM staging, which is all about tumor size and lymph nodes?
It adds a whole new dimension of biological reality.
Yeah.
I mean, they found that ctDNA detection before the surgery even happened was already highly prognostic.
Before they even make an incision?
Yes, they found preoperative ctDNA in over 82% of patients. And in lung adenocarcinomas, or LUADs, having that positive signal before surgery was linked to a much, much worse outcome. A hazard ratio of 4.74 for relapse-free survival.
Wow. So the blood test is already telling you this is an aggressive systemic-prone cancer before you even start.
That's exactly it. But, the really interesting part is what happens after surgery.
Right, because the timing there is tricky.
Timing is everything. If you test, say, a day after the operation, you'll see all this DNA that's just been released because of the surgical trauma itself. It can give you a false positive.
You have to let the biological dust settle, so to speak.
You do. And they defined a crucial window for this. They called it the landmark window.
Which was what, 10 to 120 days post-op?
Exactly. After 10 days, the surgical noise is gone. And before 120 days, you're generally testing before any adjuvant therapy would start or before a clinical recurrence would show up. It's a clean window.
And in that clean window, what did they find?
They detected landmark ctDNA in about 28% of patients, and the test was really strong. A positive predictive value of 86%.
So if the test was positive in that window, there was an 86% chance the patient was going to relapse.
A very high chance, yes. But here's where that new ultrasensitive technology becomes the star of the show. It's all about that 80 parts per million threshold.
Okay, this is where it gets really interesting for me. How did this new level of sensitivity change things?
Well, historically, that 80 ppm level was kind of the limit. If you were below that, you were basically called ctDNA negative. Clean. But with this new assay, they could suddenly see patients who were positive, but their signal was below 80 ppm.
So they split the positive group into two.
They did. You had the high positive group, so greater than or equal to 80 ppm. And now you had this new low positive group, below 80 ppm.
And what did that mean for the patients?
It created a perfect, stepwise risk stratification. The ctDNA negative patients did the best. The high positive patients did the worst. And this new group, The low positive or less than 80 ppm group, they fell right in the middle.
An intermediate risk group.
A distinct intermediate risk group that was completely invisible to older tests. So it's not a simple yes or no answer anymore. It's a spectrum, low, intermediate, or high molecular risk.
And they took this even further by combining the pre-op and post-op status, right?
They did, particularly in the LU80s. And 3 clear patterns emerged. You had the pre-op negative, landmark negative group, best outcome. They never showed any molecular evidence.
Makes sense.
Then you had the pre-op positive, landmark positive, worst outcome. The disease was there, and it stayed there after surgery.
And the third group?
The third group is the most interesting. Pre-op positive, but landmark negative.
So they had a signal before surgery, but it was gone by that landmark window.
Exactly. The surgery appears to have cleared their molecular disease, and this group slotted right into that intermediate risk category for relapse. They're a fascinating group that needs a totally different kind of management.
Okay, so let's just pause for a second. A quick recap on the prognostic value here. Pre-op ctDNA tells you about the overall severity of the disease.
Right.
And then post-op ctDNA, measured in that clean 10 to 120-day landmark window, really stratifies the risk of recurrence. And the key takeaway is that this ultrasensitive test created a brand new intermediate risk category by seeing below that old 80 ppm threshold. It's a complete game changer.
That sums it up perfectly.
So now let's move into clinical utility. If we can identify these risk groups, how does monitoring their ctDNA over time actually help guide treatment?
This is where it becomes intensely actionable. They looked at 35 patients who were positive at that landmark time point and then went on to get adjuvant therapy.
And what happened?
The results were dramatic. Patients who achieved etDNA clearance, meaning their signal disappeared during treatment, had massively improved survival, a hazard ratio of 5.56 for relapse-free survival. Molecular clearance means the treatment is working.
That makes intuitive sense. But there was a really critical detail in there about chemotherapy, right? Specifically about completing the standard 4 cycles.
Yes, and this is fascinating. It could potentially help us optimize how long we treat patients. Among the patients who got chemo, every single one who cleared their ctDNA, all 10 of them, had completed the full 4-cycle regimen.
All 10. And what about the ones who didn't clear?
All 9 patients who got fewer than 4 cycles failed to clear their ctDNA, and every single one of them relapsed.
That's a statistically significant finding.
It is. The p-value was 0.00028. It really suggests that if you can get the patient through all 4 cycles, you have a much higher chance of achieving that critical molecular clearance.
So it raises the question, should we be using ctDNA to guide that? If a patient hasn't cleared after 3 cycles, do you push harder to get them that 4th dose?
That's the perspective question we need to answer. It could also work the other way for de-escalation. If someone in that intermediate risk group clears after just 2 cycles, do they really need 2 more? This tool could help us tailor the intensity of the therapy to the molecular response.
It's truly personalized medicine. Now, beyond therapy, this dynamic monitoring also seemed to predict the flavor of the recurrence.
It did, yes. They used clustering algorithms and found 2 distinct patterns of relapse, a slow growth group and an accelerated growth group.
Okay, and the accelerated group obviously had worse outcomes.
Much worse.
Huh.
But the really surprising part was the anatomical correlation, where the cancers came back.
Right. Where did they reappear?
The accelerated growth group, the ones with rapidly rising ctDNA, were more likely to have extrathoracic relapse, so disease spreading outside the chest.
And the slow growth group?
They were more likely to recur in trickier, more isolated spots, primarily inside the chest or brain-only relapse.
That seems a little counterintuitive. Why would the slower growing tumors show up in the brain?
It's a brilliant insight into tumor shedding biology. Tumors that are confined to a space like the chest cavity or, behind the blood-brain barrier, they might not be able to shed as much DNA into the systemic circulation.
So the tumor is still growing, it's still dangerous, but it's not flooding the blood with a signal.
Precisely. The high ppm levels in the accelerated group likely represent bulky disease elsewhere in the body that has easy access to the bloodstream.
So another quick recap here on dynamic utility. ctDNA dynamics can predict if a treatment is working. Clearance is the goal, but it can also predict the pattern of relapse. Slow, persistent growth might mean we need to be imaging the chest and brain more frequently.
Exactly. It could totally change surveillance strategies.
Okay, for our final segment, let's talk about the puzzle that comes with any super-sensitive test, which is the false negatives. Why did 35 patients in this study relapse, even though they were landmark negative?
Well, first, it's important to say that with continued monitoring, The test did eventually catch most of them. The median lead time from molecular detection to clinical relapse was about 158 days,
So you still get a 5-month warning.
a 5-month warning on average, which is still incredibly valuable. But yes, those 35 who were negative at the landmark point are a really important group to understand.
And what did their tumors have in common?
They found a significant enrichment of a specific microscopic feature called the micropapillary histological pattern.
Micropapillary, I know that's considered a high-risk feature clinically.
It is, and it seems the reason it's tricky for liquid biopsies is that this pattern tends to spread locally, sort of through the air spaces in the lung, rather than forming a big, messy tumor that breaks down and sheds a lot of DNA systemically.
So it's an aggressive but tidy tumor in a way.
A tidy tumor that stays local. And that pattern was strongly associated with an increased risk of intrathoracic-only recurrence. It just doesn't put out a strong signal into the blood.
And that connects perfectly back to what you said earlier. The data showed that relapses in the chest or brain had way, way lower ctDNA levels than relapses elsewhere.
They did. The median was around 293 ppm for those relapses, compared to almost 20,000 ppm for extrathoracic relapses. The site of the disease absolutely dictates the molecular footprint.
So what does this all mean? How did this study propose we put all these pieces together into a new clinical workflow?
They proposed a refined schema, a ctDNA-guided approach. The idea is that your surveillance plan, how often you get scans, whether you need whole-body imaging, if you're a candidate for a clinical trial, all of that should be determined by both your preoperative ctDNA status and your granular landmark status.
So negative, low positive, below 80 ppm, or high positive.
Exactly. So a patient who was clean before and after surgery, the PO negative, LM negative group, might move to a less intensive surveillance schedule.
While someone who is landmark positive, even at that low intermediate level.
They need immediate intensive follow-up, aggressive adjuvant therapy, enrollment in a trial, frequent whole-body imaging. They are at high molecular risk, period.
It sounds like a complete overhaul. But we do have to remember this TRACERx cohort was treated a while ago.
That's the critical limitation. This was a retrospective look at patients treated before the modern era of immunotherapy and targeted drugs. The signals are incredibly powerful, but we need prospective trials using these assays with modern treatments to really prove we can use this to guide therapy decisions.
Right. So for a final synthesis, ultrasensitive ctDNA gives us a level of molecular detail, especially by defining that sub-80 ppm group that traditional methods completely miss. It transforms risk assessment from a simple yes or no into a granular graded model.
It does. It defines prognosis. It helps us understand treatment response, like with the 4-cycle chemotherapy finding, and it can even predict where and how aggressively a cancer might return. It's the molecular compass for the next generation of cancer care.
So, considering this data successfully identified patients who seem to benefit most from completing that full standard chemotherapy course, how quickly do you think this technology will become standard practice in defining personalized treatment protocols? I mean, ensuring we never overtreat a patient who has already cleared their disease, but just as importantly, never undertreat one whose molecular signal is still hiding just below that old 80 ppm limit.
That is the central logistical and clinical challenge we face right now.
Thanks for joining us for the deep dive.